Hello, everyone. My name is Bill Mckendree. I'm the Executive Director of the Pennsylvania Healthcare Benefit Solutions Program, PHBSP. We help people navigate through the complexities of programs like Medicare and Medicaid and the private health insurance marketplaces. We provide individual counseling and patient advocacy services, and we produce community education presentations like the one you're watching now. This presentation was made back in October 2022, and its topic is Changes to Medicare and Social Security Benefits for 2023. I hope you enjoy the presentation. Hello, everybody. Thank you for taking the time this afternoon to join us. I hope this provides you some information and maybe a little entertainment. The theme of this presentation is what are the new things in store for us for the year 2023 in both Medicare and Social Security. And I can say and Social Security because I have with me Elaine Cole from the Social Security Administration. And I'm going to let her introduce herself, and then I'm going to start pummeling her with questions about hopefully things that she can answer. So Elaine, let everybody know who you are and what you do.
Okay, my name is Elaine Cole. I've worked with Bill for quite a few years, and the partnership has been great because we have very similar audiences that we can distribute information regarding how Social Security and Medicare can affect lives and how that impact can be responded to from organizations like yours and organizations like the Social Security Administration. My job entails that I have 27 offices between Western Pennsylvania and West Virginia. The only one that I really do not service is the one in Erie and Greensburg. Those particular offices are actually done with a new public affairs specialist that is located out of Harrisburg. However, if you do have some questions that may impact those particular offices, you could always start with me, and I can give you some direction on who can assist you best with your particular consumer. At this point, I do see some people that know the situation that I'm currently going through on this call, but I do want to alert you that I will have some limited time in the office it has been limited so far, but I've been able to manage it. But as of October 28th, I will be going into some chemotherapy that may take me out of the office until the end of the year. But I want you to know that I do have a colleague that is working out of West Virginia that will take over some of the duties. So if you take my email address of elaine.cole@ssa.gov, you will be able to reach someone in Western Pennsylvania and West Virginia, regardless of what my status may be. At this point right now, I don't want you to think that there's going to be any disruption in service, but it would be not in my best interest, especially with the relationships that I have forged with each of you, so that you would know that there may be a delay in my response. In addition, what I'd like to do is, I know that I have Bill still on my information list that I send out on a monthly basis. And sometimes I might send some additional news releases that would indicate the different things that might be affecting your particular groups. It is very vital, especially now that we're going towards the post-pandemic situation, that we remain in communication so you can effectively service your clients. First of all, Social Security has changed a lot of the ways that you can contact us. We have been open to the public since April, and we are now engaged into full services that we've had before the pandemic occurred. In a lot of our national, across the country, a lot of our offices are still not open to the public because of staffing shortages, because the pandemic, of course, affected the public, but it affected our federal workers as well. So a lot of our offices are still not up to staffing. Like myself, I am working from home, and I will not be returning to the office because they did not see a need for that to take an extra space in an office at this time. But as you know, things changed based on leadership. So for those of you that have not done so or do not plan to vote, please make sure that you vote in this election. It is important. We're seeing a lot of strides, and at this point right now, we want to make sure that the American public gets the services that they so richly deserve. So that is important. In addition to that, there are going to be a lot of changes that you'll see in 2023, and I'm sure Bill is going to start talking about those different subjects. Please make sure that you make annotations of the different things that you should be looking for so you can alert the public if they have not heard. In addition to that, you may be seeing some things that I will not be able to confirm or deny. I'm starting to sound like a politician myself. At this point right now, Medicare is in the process of making some changes, and we're going to further discuss that today. But most importantly, Western Pennsylvania, West Virginia is open for business between Monday through Friday between 9 to 4. Well, only exception is during the holidays. And above all, if you or your consumer has not contacted Social Security in which to conduct business, please be very, very wary of that particular phone call that may be coming in asking for personal identifiable information. If it is something that you're not sure about, find out where that person works. If they have a definitive phone number that you can call them back. Do not use that particular phone number, but get the number that you have for your local office. Investigate. Protect yourself. That seems to be the theme that we were having, especially during the pandemic, that there was an issues that people are getting these phone calls unsolicited, and they're finding out that they have their Social Security information, personal identifiable information has been given to an unauthorized source, and they're finding that they're having bigger problems which may be affecting their money with Social Security benefits. So therefore, please engage your particular consumer, also protect yourselves against all of this fraudulent activity. Lastly, I'm sure that we're going to be talking about how we can save you money, how we can direct you to different areas in which that your particular consumer can engage in some of these cost-saving activities, especially with healthcare. And that's why I love speaking with Bill, because he has a reach that is out there with the public that if you want anyone to show you the money, he's the man that will do it.
I'll take it out of my pocket and let you look at it and make you happy. And actually, you've already answered a bunch of the questions and that I was already thinking of. I got a couple others, and then I'm going to open it up to the audience in general if they would like to ask a question to Elaine or just tap her wisdom. Let me ask you this. You mentioned that the Social Security offices are back on track of getting to their pre-pandemic functionality. Can you give me an idea of certain things that they really collectively, generally aren't prepared to do that they used to do, and that we should anticipate finding a more virtual way to do it, or an alternative way of coming into the local offices? There's still stuff that they would prefer that you do online, or they would prefer doing with a phone conversation.
Well, the preference is if it's something that cannot be done online and you were trying to schedule an appointment, they will let you know if it's something that cannot be done online. The situation is, if you're trying to get retirement benefits, of course, the preference is that you would go online because we have all the information that is necessary. But whenever you're doing an online application, the assumption is that you've had your questions answered. And a lot of times you may make a decision because you were uneducated in regards to the different options that you may have. An example of that would be that you have an opportunity in which to start collecting your Social Security benefit, your full retirement age. However, you had a spouse, or it might have been an ex-spouse that has passed away, that you do have the option of collecting benefits off of their record. And you know that your particular benefit can continue to grow up until the age of 70. So therefore, you're looking at that it could, if you're 67 is your full retirement age, then you have 3 years that you can actually increase that benefit by 8% per year or 24%. That could make a big difference in regards to the finances that you have in that overall plan. So therefore, you may decide, you know what, I'm going to collect my survivor benefit as opposed to my regular benefit because I know it will continue to grow. I am relatively healthy. I do not want to, I want to maximize what I can get from Social Security. But if you don't know about that option, you might sign up for your own retirement benefit and find that that was an incorrect option to take. So if that's the case, then I would suggest either calling myself, and of course, you can always contact me. And again, Bill has that information. And then we could discuss that on a one-on-one personal level. And then at that point, if you decide, yes, I'm going to do a survivor benefit as opposed to my own benefit, so you could do that online. But if you've already started collecting a benefit, unfortunately, that's not something that you can do online as of yet. Our technology is not that experienced. So at that point, you would have to make an appointment. You do have to make an appointment for that. The reason being is pre-pandemic, sometimes we did have particular claims representatives available in which to take your claim on a basis of just waiting a few minutes and they would become available. We don't have that option anymore. There's no more walk-ins. They would have to have an appointment to schedule that particular type of application, especially with disability. If you have a disability application, you must have an appointment because that particular appointment could take up to 2.5 hours in which to process. A lot of times people would come in asking to have that appointment to find out they don't have all the details in which to complete the application. Therefore, it is best to collect all of the information because there is only a 2.5 hour window for that disability appointment.
Are there any walk-in functionalities that we can anticipate a normal community office would do then still?
If you needed a replacement card, you don't have a driver's license, but you have your passport. And of course, you don't want to mail in your passport. Just bring that information into your local office between 9 and 4, Monday through Friday, and we would be able to process it. But things that take a longer time that you may have questions, that's when you have to have an appointment.
And are there any boundaries for people wanting to reach out to you directly? I want to avoid you getting overwhelmed with people that want to get to the best and brightest, and you happen to be the best and brightest.
Well, Achieva knows, and I see several Achieva folks on this call, know that overwhelmed is my middle name. So overwhelm me.
Much appreciated. Let me ask a more technical question, and this and the next couple have to do with the process of getting into Medicare. So I get it. We're going to take more responsibility to do this online whenever possible, when it's a function within the Social Security Administration or the Medicare benefit process that's tasked to the Social Security Administration. So one of the typical utilizations of the online function is to enroll in Medicare Part A or Medicare Part A and Part B at some point in time. So what I've been wondering, and this seems to be a moving target as far as expectation, depending on the pandemic, now the post-pandemic. So when I submit my application online, when I go to ssa.gov, complete my Medicare application, hit submit, I get the pop-up saying, congratulations, you completed the application correctly. What's my turnaround time? How long is a reasonable time to anticipate that I'm going to get some kind of notification, and from whom, and how's it going to be done? And what's the process wait time so I know I'm waiting enough time before I start getting a little antsy?
Okay, well, the real deal. Right now, our payment centers are at least 6 to 8 months behind in processing disability claims, meaning that it's the SSDI, meaning that that's tied to the Title II benefits, meaning bottom line is someone's work history. It is not because it's a income or a resource need application. So if it's anything that is attached to someone's work history, because of the pandemic, because of the work shortages, because of at the beginning, we wanted people to have their particular COVID shots, and some have chosen not to have that. All of that delayed processing. So therefore, a lot of our information is backlogged 6 to 8 months in the payment center. As for the local offices, if it's something that is a simple application, we're able to adjudicate that information from the local office, and it will go through processing through our normal technology. If you did a retirement benefit online and it was a simple process, that your date of birth, your name, your address, nothing was missing from the application. If we do a return call just to verify that you are who you are, that is usually done within a 3 to 5 day period. Once we are able to process the application, that information will usually take place within a 2-week period or a 10-day processing time. So you should receive your particular benefit on time, meaning that you indicated in your application that you wanted October to be your first month of entitlement. Reminder is that if you want retirement benefits, we are a month behind. So that gives us some lead time, meaning that your check isn't due until sometime in November. So therefore, it seems that it would not be a long wait because you're not expecting your check until that following month. But in the meantime, Social Security within 10 days is going to send you a letter, and it's going to indicate when your first particular benefit will be payable. But a lot of times you will see that that letter is an indicator that that particular payment is already in your account. We seem to have our letters show up after we've already paid you.
Now, by letter, we're talking about the old-fashioned snail mail type letter.
That's correct. That's correct. We still believe in the United States postal system.
And can we assume that the Medicare online application is one of those simple kinds of applications that have approximately a 2-week turnaround time?
Yes, that is correct. Most likely, you'll see your red, white, and blue card before you will actually see the letter saying, congratulations, you've been enrolled in Medicare. And it would also have the amount that you're going to be charged. Now, there is a slight delay for those that are engaged in IRMA, or that tax penalty that is usually assigned to those that from 2 years prior had a higher income on their tax return. There would be a separate letter indicating what that charge would be as well.
And that might take a bit more than 2 weeks then.
Correct.
Now,
I'm looking at your chat, and there is a couple of questions on the chat that I wanted to address.
Yeah, go ahead. Go ahead.
Robin Hausman, I hope I said your last name correctly. Okay. All right. When a person makes an appointment at an SSA office, are they automatically told what documents, information they will need to bring when must they ask? When you make the appointment, a letter will be sent out to that person indicating what documents are necessary to conduct that interview. And it says specifically the date, the time, when that appointment will be made as a reminder, so that they bring that particular checklist along with them the day of the appointment, or either that they're by the phone at least 15 minutes before the appointment, just in case that claims representative is free earlier than that specific time.
Let me spin off of the question I was asking you before. So if all goes well and I've submitted my Medicare application completely correctly, I can expect, under ideal circumstances, a turnaround time of about a couple weeks, even just not ideal, a couple weeks. Well, what if I've screwed it up? Let's say I'm submitting a Medicare application and I need to attach something. So I've delayed my enrollment into Medicare past age 65 because I was working. Now I've decided to stop working, and I've got a document from my employer, and it's called the L564. This is the document that the employer vouches that from the time I was 65, I was working for this employer and I was covered by that employer's health benefit, which is my exception, allowing me to delay enrolling in Medicare, in my case specifically Part B, because I didn't want to pay the Medicare Part B premium since I have a perfectly adequate employer benefit. But now that I'm 69, and I'm entering Medicare, and I'm going to do it online because I want to do it that way. But, damn it, I forgot the L564 and I submitted it. Now, how do I reconcile that with the Social Security office? What office? And is that going to booger things up terribly, or is that easily correctable?
Nothing is easy.
Thanks for the reassurance.
Well, first of all, if that is the case, that this person was working and they're submitting their documents, it is best to submit that information at the same time.
To be sure.
Two responses may occur. Number one, the person that is processing that particular application would give a call to you to correct it.
Somebody from the Social Security would call the applicant and say, you know what? I've noticed something's missing.
Correct.
Okay.
However, just a reminder, remember that you are the ones that submitted that particular Medicare information. So this isn't an unsolicited call. There's something going on that's why we called you. So at that point, please answer the call. It will not say Social Security. It will probably give an 800 number. It may say something like U.S. federal government. It may just be an unidentifiable 800 number. However, if you know that you submitted an application to Social Security, regardless if it's Medicare or a Social Security application, you may want to take that call because there's additional information that is necessary or just verification that you did this particular application. Number two, if we're unable to get a hold of you, we may process it because we don't have any other alternative, or we might just deny it because there wasn't enough evidence to say that you should not have a penalty. We would follow up with a letter to indicate to you that we're trying to get a hold of you and you need to contact us at a specific number, which would be included in that letter. But again, that's delaying your process of the application. So you need to read that letter and respond to the letter. In other words, if we may have tried to call you once, maybe twice, and we'll just close out the application stating that we're just not able to process it because there's missing documents. That whole process, especially if it was done by the payment center, is going to delay your Medicare for 60 days. Often we can reopen the application, but we have to get concurrence from the payment center to transfer your particular application from them to your local office so we can update it with the proper documents. That whole process, I have seen that it takes up to 6 months. That means that you don't have Medicare for that time period. So the best practice is before you hit submit is that you are sure that you have your checklist of all the items necessary to complete that application. If you do not hit the submit button.
And if I've realized I've screwed up, just after I sent it, after I've submitted it.
Call your local office.
What you're not saying is don't try to submit a new version of the application with the attachment. Could that booger things up even more?
Correct.
All right. Because I've had clients do that and somehow it ends up in Baltimore. You know why we don't want it to end up in Baltimore.
Absolutely not.
Okay, we are going to shift to Medicare. And every so often, I'm going to say, hey, Elaine, can you confirm that? And you'll say, no, Bill, I can't confirm that at all. So we're going to take a big leap of faith that all of this stuff, though not official, is actual and satisfactual.
While we're waiting for Bill to do that, just a reminder, please be watching out. By the end of the week or the beginning of next week, we should officially be announcing the cost of living increase. It should be up to about 8% minimum, but it should be a little bit more, but we don't have those final numbers as of yet, or at least we haven't announced the final numbers.
Well, I thought you weren't allowed to say that.
That's the cost of living with Social Security. I can't say anything specific
anything else
about Medicare.
Okay.
Except that they're going down.
Yes. So we're going to look at that and some other stuff, and some stuff I found pretty interesting. And most of the stuff has just been revealed in the last week. Some of the stuff started trickling in on September 27th. So maybe closer to 2 weeks now, but this is kind of hot off the presses. And literally the past 48 hours, I've been scrambling to pull all this stuff together. You're going to find some things that have changed significantly, some things that have changed a little bit, but this is an interesting year, transitioning from 22 to 23. And by the way, before I get off this slide, if you have any questions or concerns and want to reach out to me, there is the best way to do it. There is my email address, william.mckendree@phbsp.org. And that's our program's phone number. Better way to do it is sending me an email. I'll try to get back to you within about 24 hours and set up an appointment so that we can talk about your situation. So I'm showing this slide to establish just a common vocabulary, a common concept, because we're going to be talking about a bunch of parts of Medicare. And think of this as just kind of your introduction, as your introduction to the system. So anybody going into Medicare or anybody already in Medicare is going to be in one of these two categories in terms of building their coverage strategy. If they're going to be in option one, they're using Medicare Part A and Part B as their primary coverage. They're then supplementing Part A and Part B with a private insurance product, possibly provided through an employer retirement benefit. More likely, they went off into the marketplace on their own and bought themselves a supplement. And if that's the case, they're typically referred to as Medigaps. But the point is, whether an employer provides the supplement or whether you purchase the supplement, it is typically through a private insurance company, like, for instance, Aetna. And it typically, in this case, is relatively comprehensive in covering the parts that Medicare Part A and Part B don't fully cover. And it is absolutely a secondary benefit. And something else. If the provider, the doctor, the hospital, the clinic, agree to take Medicare A and B, and for all intents and purposes, just about any provider in America is likely going to take Medicare A and B, then by rule, they must also take any insurance company's supplement, a Medigap or an employer's supplement as well. The individual is also likely going to pick up a standalone Part D plan, separate from Medicare Part A and B, separate from the supplement. So they're going to have four parts: Medicare A, Medicare B, the supplement, and a Part D plan. And they might also have stuff that isn't under the Medicare umbrella, stuff like basic vision coverage or basic dental coverage, things that aren't even truly connected to health care services, but kind of sort of. That would be option one's concept. Medicare A and B is primary. A supplemental private product is picking up all or most of all of the balance that A and B doesn't pick up. A standalone prescription drug plan is there to help with the cost of acquiring their prescription medications, and they may have some other kinds of services to cover some of the things that aren't under the Medicare umbrella. The alternative to that is that an individual would still be enrolled in Medicare A and B. It would still serve as their platform, but they won't rely on Medicare A and B for their coverage. Rather, they're going to be enrolled in what's called a Medicare Advantage plan, also referred to as a Medicare Part C, C for Charlie plan. These are managed care HMOs, health maintenance organizations, or PPOs, preferred provider organizations, or some hybrid of those concepts. The key concept of any Advantage plan is it's going to have some sort of a network of providers. And to maximize the care and the coverage that the Advantage plan offers, you're going to stay within that network that the HMO or PPO offers. They will usually offer things that are beyond the umbrella of Medicare, things that Medicare Part A and Part B or the Medigap supplement wouldn't cover because it's not part of the Medicare system. Things like basic vision services, basic dental services, health club memberships, concierge services to help navigate the patient beneficiary through a process. All of these things are offered as additional swag, as an incentive to get the person to go with option two rather than option one. And for some people, those things are important. They're valuable enough that it's a motivator. For some people, getting a more comprehensive coverage and more accessibility beyond just even Western Pennsylvania is the value. This is not what we're talking about today. But whether you're in option one or option two, you're going to be looking at these products on a regular basis. Now, your Medicare Part A and Part B, you've got it. It's there. As long as you are going to be in Medicare, which presumably will be for the rest of your life, you're going to have Medicare Part A and Part B probably. It is the platform you must have to get anything else. Whether you use Medicare A and B or not, you still must have it, or else you won't be able to get the Medigap, you won't be able to get the Medicare Advantage plan. Ironically, you can get a Part D plan with just Part A or Part B, but that's about the only thing you can do with just one of those products. Most people that are fully in Medicare are fully in Medicare. They have the A and the B and the other private insurance products that go with it. And every year, they're likely going to evaluate what they've got and say, is it working? Is it affordable? Is it accomplishing what I want it to do? And during each year, there is a period set aside called the annual enrollment period for Medicare. It typically begins October 15th, and it typically runs to December 7th. And in that period of time, individuals make evaluations of their coverage. An Advantage plan, an HMO or PPO, can be changed during that period. It goes into effect the first day of the next year, January 1st of the following year. And if you don't change it, if you allow the product you currently are enrolled in for this year to simply roll over, it will continue to be in effect for the upcoming year. You also do this evaluation with your Part D drug coverage. Even if you have under option one a Medigap, which likely you're going to hold on to forevermore, although some people give them up. But whether you're going to keep or give up your Medigap, you are definitely going to or should reevaluate your Part D coverage every year to see if that current Part D plan you have now is going to cover your prescription medications that you're taking for the following year. Are those meds that you're taking now and plan to be taking next year, even though they're on that plan's formulary now, are those meds going to be on the plan's formulary next year? And at what level of cost sharing are those drugs going to be on the current plan for the upcoming year? Plan Ds change. And in that change, they may leave you with lack of coverage for the meds you're taking or anticipate taking, or a cost sharing that can be more than other plans will offer you. But you won't know that until you take a hard look. So this is the time, whether you're in option one and you're still going to check your Part D coverage for the upcoming year, or option two, you're going to pretty much evaluate your entire coverage strategy to see if that's still going to work the best for the upcoming year, or whether there's changes that you want to make to it. So knowing that, and knowing that we're in this time, we're going to look at the things that you have a active role in participating and things that are just going to happen and they should know about. So let's start with the fundamental of Medicare, Part A and Part B, the government portion of it, the platform, what we call original or traditional Medicare. So I can tell you right now, there's going to be some premium changes for Medicare A and B for 2023, and some surprises in those changes. So well over 90%, usually in any given year, well past 95% of the people in Medicare pay no premium for their Medicare Part A. Individuals that have worked less than 10 years during their lifetime in the United States and or fail to pay in to the Medicare system for at least 10 years. Those individuals actually do have a premium that they have to pay to have their Part A. Most individuals, this is going to be a non-issue. As long as they've worked at least the requisite 40 quarters, think of each year having 4 quarters, so 10 years times 4 quarters, there's your 40 quarters. Or they are married to someone who has the requisite 40 quarters. Either they're 40 or the spouse is 40. They can't merge. Oh, I got 10. Oh, I got 30. No, neither of you have 40. And as a result, if one or either cannot come up with the 40 quarters, then we're anticipating a cost for the Part A itself. Now, that acquired their 40 quarters, or through a spouse has acquired those 40 quarters. But if it's less than 40, between 30 and 39, currently the monthly premium is $274. And if it's less than 30 quarters accumulated, the premium is almost $500 currently this year. That's going to change. It's going to go up, whoops, just a bit, to $278 a month for individuals with 30 to 39 quarters, and just topped over $506 for individuals that have less than 30 quarters. Now, you can rehabilitate your lack. Absolutely, positively will always have a premium cost. Part A is presumed that you acquire it at no cost by having worked and helped support the Part A system. Part B does not have the capacity to pay in while you're working with an expectation of a free Part B premium. Part B is an immediate benefit with an immediate payment requirement. Now, in 2021, there was an expectation that Medicare was going to be overwhelmed in 2022 with costs based on just the inflation of healthcare, but also the introduction of a medication called Aduhelm. It was a medication that was going to be a breakthrough med for the treatment of Alzheimer's or dementia in general. And because of the publicity, because of the anticipation, because that care providers were inundated with individuals and families saying, can we try the Aduhelm? And because the cost of Aduhelm was incredibly large, we're talking $52,000 for a 12-month treatment. And this was not a marginal orphan drug that only a handful of people would be using. This was going to be a significant utilization based on the number of people that were petitioning their physicians if they could utilize that. And so as a result, Medicare was anticipating being inundated with a significant bump in cost because the Aduhelm was administered intravenously. It would be administered in a doctor's office, and it would be done under Part B of Medicare, not Part D, not shifting the economic responsibility to the insurer and the patient, but picked up significantly by Medicare directly under their Part B. For individuals that had that option one, Medicare A, Medicare B is their primary, they expected Medicare would pick up 80% and their Medigap would pick up the balance, the other 20%. Their attitude is, I don't care whether it's $52,000 or $52 million. Medicare's picking up its share. My Medigap will pick up the balance. I want to try the Aduhelm. And with that expectation, Medicare was looking at the possibility of a significant increase in the demand and the resources of the Medicare system. And that prompted them, going from 2021 to 2022, to increase the resources that they were taking in. And one of the big increases of resources was to increase the Medicare Part B premium for 2022. It represented, from 2021 to 2022, about a 15% bump, and even a bit more for people that had larger incomes that were measured for 2022. It represented, if not the biggest, one of the biggest bumps in Medicare Part B premium in the history of Medicare. And it didn't set well with many individuals that saw this increase as a significant hit into their source of income, especially lower income individuals. And so, honestly, we were anticipating maybe not a 15% bump again, but a significant bump because of inflation again. And a tell for the indication of an increase was that Social Security was, and I know, Elaine, you can't say this, but you can, you did say it sort of officially, about an 8% bump. That's a big bump. And usually when there's a bump in Social Security benefits, there's a corresponding bump in Medicare Part B premiums. So I was thinking months ago, it's probably going to be in the neighborhood of equivalent to Social Security. Since they were even then talking about a 6, 7, 8% Social Security increase, I'm thinking probably a 6, 7, 8% increase in Part B. But guess what? This is what 2022 looks like. A base premium amount of $170.10. And if your income is higher than a certain amount, you'll also be required to pay on top of that Medicare Part B premium an income-related Medicare adjustment amount, an IRMA. How big is the IRMA? Depends on how wealthy you are in the measurement for your determination of your Part B premium. Why didn't I just say, well, how rich you are in 2022? Because they don't use 2022 to determine. For this year, 2022, if you go into the Medicare system, if you pick up Part B, your premium for Part B is going to be determined by the Medicare system, the Centers for Medicare and Medicaid Services, going back 2 years, 2020, and looking at your federal tax information from that year to determine your wealth, your modified adjusted gross income. And if it is over a certain amount, what's a certain amount? Well, for an individual's tax return, $91,000. For a married couple filing a joint return, $182,000. It's above those amounts, you'll be paying some IRMA. And the more you are above those amounts, as you can look at the chart, the larger the IRMA is. The IRMA is then added each category onto the 170. So that next category above the base amount, a $68 IRMA, is added to the $170.10. And the new Medicare Part B premium for the year 2022 for that person is $238.10. If that individual's income is higher, even if they have a spouse who's not going into Medicare, but they file a joint return, they're still going to look at the joint income. And if that's within the category of $228,000 to $284,000, their IRMA is going to be $170.10 added to the $170.10 base amount. So their Medicare Part B premium for the year 2022 would be $340.20. So you get the concept. Here's what happened for 2023. Oops. The Part B premium went down. I mean, not a lot. Going back, 170, going down to 164.90, so about $5. But the point is, it didn't go up. We're in the grips of a significant inflation. And yet we've seen one of the few times that the Part B premium goes in reverse. It's almost inevitable, even in a relatively stable economic year, that the premium inches its way up, or at least stays where it's at. This is a true anomaly. Again, not much of one, but hey, considering what it could have been, this is actually a nice little benefit. So don't think of it as, oh, it's only a $5 drop. Think of it as the $5 drop and the 8 or 10% that it didn't go up. So that might make a significant difference. Now, we still have the IRMAs, but the IRMA amounts have also reduced a bit. So just looking at the first category. So the IRMA this year, 2022, is $68. It's now down to $65.90. And the IRMA in the next category, this year it's $170.10. For 2023, it'll be only $164.80. So not only has the base amount been reduced, but also each of the IRMA categories have been reduced a few dollars. And in addition to that, for the benefit of the individual going into Medicare, the income that's being measured to determine which category of IRMA is being applied, or if there's any category of IRMA that's going to be applied, that's gone up a bit. So they're allowing you a bit more income for the year 2021, the measuring year for 2023. They're keeping the base amount a bit lower and the IRMA assignments a bit lower. So we're getting a pretty good break in 2023. Something that was announced at the tail end of September 27th, it was announced. I'm not sure whether this is official, but it was CMS that threw out the information, so I'm assuming it's reliable. And again, Where are they going to determine the income that they're going to use to base on the Medicare Part B premium? They're going to look back 2 years. So for 2023, they're going to look at your 2021 income from your federal tax information. If you filed a return, they're going to look at that for the adjusted gross income. If you didn't file a return for the year for whatever reason, they'll look at the accumulated tax information, like your 1099s and W-2, and essentially construct a return information from that. You can challenge the determination. You can ask for a reconsideration if you feel that the use of 2021's income is an unfair indicator of what your current income is. And you make your request, you submit the information that supports your argument, and usually you have a pretty good chance of making your point if, in fact, the current year you're in, make this 2023, is a smaller reflection, a lesser amount than you had accumulated for the year they're using, 2021. And it's how well you make your case. But you are given that opportunity, and you're told when you receive the letter that tells you what your Part B premium is going to be for the upcoming year. It also tells you that because they've added an IRMA amount to that, you have the opportunity to challenge that and ask for a reconsideration and a recalculation. If you don't, if you have an IRMA amount assigned to you for the particular year and you don't challenge it, you can also know that every year there is a redetermination. Regardless of what the base premium is for Part B, regardless of what the IRMAs are, the Centers for Medicare and Medicaid Services will look back 2 years, whatever the 2-year look back is. So this year, it's for 2022, looking back at 2020. For next year, it'll be 2023, looking back at 2021, and so on. And so whatever the determination made in one year will be changed automatically, absolutely, for the next year. This could be good or bad from your payment perspective. If you have a lesser year in the future, then presumably your premium will be lesser or at least stay at the base amount. But if you have an increase year in the future, eventually, like a pig working itself through a boa constrictor, it's going to show up. It's going to proceed within a 2-year period to affect your Part B. Here's something else. A lot of people don't know this, but not only does that increase of income, that above the base amount, not only does that impact on the amount they pay for their Part B premium, B as in basketball, it also can add to their Part D, D for dog premium. And here's an example. So I'm not showing the 2022 information. This is just for the upcoming year. But there are individuals currently this year that are paying more onto their Part D premium because their income for 2022, they'll look back to 2020, indicates an income higher than the base amount. So for 2023, CMS is going to look back to 2021. If they determine for a single individual the income is above $97,000, then that individual not only will pay whatever their Part D premium is, they'll pay something in addition. So that's why I put 0 in the first category. 0 is the IRMA being added, not that you get your Part D for free. It's whatever your Part D premium is and add to it. What? Well, if you're single and above $97,000, add $12.20. And if your income is above $123,000, add $31. Geez, that's more than your premium actually is. And $50 and $70. And why is my premium so high? Because your income is so high from 2 years ago, and it has double effect, increasing your Part B and increasing your Part D. So when individuals are going into Medicare and saying, what's this going to cost me? For those individuals whose income in the 2-year look back bumps their Part B up, they also have to start anticipating how it's going to bump up their Part D as well, adding even additional costs. So, and this is why often individuals that generate a significant amount of annual income and know that income is not going to go down even after they retire, they are reluctant to go into the Medicare system, especially if they don't mind working or actually enjoy working. They'll work for a long time because likely whatever they pay for their employer health benefit is going to be a lot less just than the Part B premium and the Part D premium IRMA. And again, in keeping with the reduction of the Medicare B concept, get ready. So Medicare Part A and Part B not only have a premium that you have to pay, well, Part A not if you work your requisite 40 quarters, but Part A and Part B both have cost sharing. If you just relied on Part A or Part B for your coverage, which once upon a time lots of people did, not anymore, but this is what you would be looking at. This is why you would get a supplement or replace Medicare A and B with an Advantage plan. So looking at currently this year, if you had Part A and went into an inpatient facility, an acute care facility, a hospital, your initial deductible, the amount you would be responsible for before Medicare Part A would kick in, would be over $1,500. It's a deductible. It's your responsibility initially, and you don't actually have to pay it. You're going to be billed it. You're expected to pay it, but the billing of it, the assigning of that amount, then triggers Medicare Part A to step in, and they will pay the entire cost of your daily expense for the first 60 days once you've met your deductible. Once you've reached the 60th day on the benefit cycle, then you have a payment requirement. Your co-payment is $389 per day, but that's only after you've reached the 60th day. Now, if you exceed even that second tier and are in facility for a benefit cycle or have a benefit cycle that exceeds 90 days, then there's one more fallback. It's called your lifetime reserve. You get 60 days, but the cost is escalated a bit. Currently, right now, it's $778, and that's only for 60 days. And those 60 days is your lifetime reserve. Once you've used those up, the longest you will stay with help from the Medicare system, if you're just using Part A, is 90 days. The first 60, you meet your deductible. Medicare Part A covers the next 30, 61 to 90. You've got some cost sharing. And after that, hey, it's on you. Here's the thing. Most people are not going to be inpatient long enough to worry about getting past the 60 days even, let alone the 90 days. And two, most people are not going to rely exclusively on Part A. They're going to have some private insurance that enhances. Very likely, Part A is going to be a minimal cost because of the additional private insurance. This is one of your least problems, although it's the thing that worries the people the most. There's another aspect of Part A. And by the way, notice it went up a bit. So here again, 2022, a deductible of $1,556 and a daily copayment for your next 30 days of $389. Watch carefully. It goes up next year to $1,600, and the daily after day 60, from day 61 to 90, goes up a little bit to $400 per day. And your lifetime reserve, the 60 days that you have past the 90th day, you still have now an $800 cost share on that. And once you've used up that, forevermore, after 90 days, you've got an entire cost. But again, I wouldn't worry too much because you're going to have some kind of additional help with private insurance. So here's the other thing you need to be aware of. Not only is being in hospital, in acute care, have deductibles and copays, being in a skilled nursing facility, a rehab facility, also has cost sharing. Now, currently, 2022, if you are in a rehabilitative facility called a skilled nursing facility, and for the first 20 days, and you're using Medicare Part A as your primary coverage, Medicare Part A is responsible for paying the entire cost of those 20 days. After 20 days, from 21 to 100, you're responsible currently for $194.50 per day till you reach day 100. After that, that's it. You are now no longer covered by the Medicare system for being in rehab, the skilled nursing facility. And unless you can reset the clock and be able to start another set of 100 days, which is not likely, you're either going to pay full cost to be in the rehab facility as an inpatient, which is not likely, or you're going to transition into a long-term care facility, which is very likely. And it is not going to be $194.50 a day. Now that's gone up just a bit. So 194 from day 21 to 100. It's now up to an even 200. Notice the first 20 days are still Medicare. Part A pays that amount. And then from day 21 to 100, $200 per day. After that, just like it was this year, it'll be next year. Medicare is not going to cover at all. You are now considered in long-term care mode, and you're going to find other ways to pay for that. Part B is different. Whereas Part A went up a little bit, Part B went down a little bit. So how does Part B cover? Once you've met that premium of 174 this year, or I'm sorry, 170 this year, and next year $164.90. What's your expectation of what Part B is going to do? Well, Part B will cover 80%, but only after you've met a small deductible. What's the small deductible? Currently, right now, this minute, it's $233. Once you meet the $233, Medicare Part B steps in and says, we'll pay 80% for the balance of the year. And you're on the hook for the other 20%. So your initial deductible, specific amount, and that amount, small as it is still your requirement. So you see the doctor at the beginning of the year, the doc says, my cost is $400 for this. Medicare will say, well, pay $233 of that yourself. Now you've met your deductible, and the balance will split at 80-20. But here again, a person that has Medicare Part B as their primary coverage is very likely going to have a supplement, a Medigap. And that Medigap will very likely pay the entire 20%. So between Medicare's 80% and the Medigap's 20%, the 100% of the service is paid. Think back to what I said about AduHelp. You show up at the practice and say, I want to get an infusion of AduHelp, and that's a Part B, B for banana service. And the physician says, okay, before we start, how are you paying for this $52,000? And you say, here's my Medicare card. That'll cover 80%. And here's my Medigap. That'll cover 20. Hook me up. Well, you owe the deductible. Well, maybe my Medigap also pays the deductible. Maybe it doesn't. But for $233, and knowing that the rest of my outpatient services under Part B are going to be fully paid for by Medicare and my Medigap, wow, that was worth the premium. But next year, pay attention to the annual deductible. It's going down. Oh boy, it's going down by $7. It's not just that it's going down, it's that it also didn't go up. It's still an 80-20 split. That is likely going to be always 80-20. But the good news is that the annual deductible for Part B has dipped a bit. I was anticipating it was likely going to be kissing close to 250 this upcoming year. Not quite, 226. Again, small benefit, but hey, take advantage of it. Enjoy it. Here's what else is changing. Medicare enrollment changes. This is a little bit more complex than just here's the numbers and here's the other numbers. So this is how you go into Medicare currently. Now, if you were going in based on disabled, it doesn't work this way. Medicare is going to be given to you automatically through the Social Security Administration because they're keeping tabs on you. If you've applied for and were accepted as disabled and you now start collecting your Social Security disability benefits, they're tracking you to see when you suddenly and eventually become eligible for entering Medicare. And about 2 to 3 months before that, they're going to send you out a package. Here's your Medicare card, A and B. Oh, and by the way, because you're getting Social Security, you have to take Part A, but you could turn down the Part B, but you have to get back to us in time to let us know. This is not that situation. This is the situation where the person is reaching age 65 and they're not collecting Social Security and they're not being attended to. It's their responsibility. So the rule is, if you wish to enter Medicare, when you are turning 65, you have a 7-month period to do this. So let's use me as the example. I'm going to turn 65 in April of 2023. So if I'm looking at this, I'm saying to myself, well, I want to be reaching out within the right period. What's the right period? The 3 months leading up to the month I turn 65. So I would want to reach out in January, February, or March of 2023 and say, hey, I want to get Medicare A and B, or maybe just Medicare A. But if I reach out in those 3 months, if I fill out my Medicare application online, submit it, it's approved, I didn't screw anything up, I have an expectation the first day of the month I turn 65, here's my Medicare A and B, and I'll get my card within, as Elaine said, a couple weeks after I submit my app. Everything's just hunky-dunky. Now, exception to that, if my birthday happened to be the first day of April, but it's not, but if it was, I would get to go in 1 month early. So my initial month would be April, it would be March, and my 3 lead-up months would be December, January, February. But it's not, so January, February, March. If, according to this, I didn't reach out in January, February, or March, my 3 lead-up months, if I reached out in my birth month, even if it's before my birthday, I'll go in to Medicare A and B earliest the first day of the following month, in this case, May. If, according to this chart, I decided not to enroll or reach out in the 3 months leading up to my birth month or my birth month, if I reached out the month after my birth month number 5 in this case, this one, May, I won't go in the following month. I'll go in 2 months later, not June, but July. And if I waited till 2 months after my birth month, the 6th month in this cycle, in this case, that would be June, I wouldn't go in July. I wouldn't even go in August. I would go in 3 months later, September. And if I waited till the very last month, which I certainly could, I'm not late, but I'm going to go in later by 3 months. And this bedeviled people that it's like, oh, I was going to go with my employer plan, but my employer dropped me, and now I'm kind of in the end part of this, and I tried to enroll, and they said, I got to wait 3 months. It's like, wait a minute, why? It's like, I don't know. You piss somebody off. What can I tell you? But watch. Look, I don't have to worry about that. I don't have to worry if I'm going to be going into Medicare next year about, oh my, what if I screw this up? What if I have to wait? This could make me wait even longer and longer and longer. No, starting next year, starting the beginning of next year, the new cycle, still 7 months. I'm still born in April. It's still April 17th, but the new paradigm is the 3 months leading up, still January, February, March, I'll go in the first day of my birth month, April 1st. If I wait till April, even before my birthday, anytime in April, I'll go in the next month, the first day of the next month, that would be May. But thereafter, I don't have to wait a couple or 3 months. It's going to be always the first day of the next month. It's simplified. It's easier. It's get them into Medicare. I don't care why they waited or screwed up. If the worst thing that'll happen is you're going to be late by I didn't get in my birth month. It's the month after, maybe the month after that, or the month after that. So it's simpler and it's easier. Just know that if you wait till after your birth month, there's always going to be a 1 month delay, first day of whatever that month is. But what about the people that want to delay? Legitimately don't want to go into Medicare when they're turning 65. So who would be able to put off going into Medicare when they turn 65 without an adverse effect? If you are employed by a large employer, or your spouse is actively employed by that large employer. What's a large employer? 20 or more employees. And by working for that large employer, the individual is covered by the employer's group health insurance. So I work for someone as I'm turning 65 and I've got health insurance, or my spouse is working for someone and my spouse has insurance, but I also have insurance, and that's the key. If I'm covered by a large employer's health benefit plan, as I'm approaching 65 and past age 65, I can legitimately turn down Medicare. What parts? Well, if I'm not collecting Social Security at the time, I can turn down Part A. And even if I am collecting Social Security, and I'm going to have to take Part A then, I still can turn down Part B and go back to what we were talking about with the Part B premiums. It's like, yowies, I sure don't want to pay that kind of money because I'm really rich. Honey, I want you to keep working for a while so I don't have to pay that premium. And she'll say, okay, you'll die anyway soon, so it doesn't matter. So at that point, it's certainly going to inform me of how I make a choice. And in this context, the postponing for various reasons. One, the benefit looks good. And even if I'm not subject to an escalated cost for Part B or my Part D, I'd still rather hold on to the employer benefit rather than going to Medicare at this point. And that's okay. So I tell you that because there's another way to go into Medicare if you passed age 65 and didn't pick up. This is not a good way. This is called general enrollment. So if I postponed going into Medicare, particularly the Part B, because that's going to carry with it a premium that I'm avoiding. If I avoided picking up Medicare Part B, and I didn't have a legitimate excuse, meaning I wasn't working for an employer, and my spouse wasn't working for an employer, we just didn't want Part B. Who would not want Part B? Who would take the Part A and not the Part B? Someone that doesn't need the Part B to effectuate their coverage. Who would that be? I'm going to rely on the VA system for my health care. So I don't even need Medicare Part A, let alone Part B. I'll take the A because there's no premium, but I'm not going to take the B. Even if it's only $170, I'm not going to take the Part B. There. I just saved myself money and I put my foot down for liberty. Or, ironically, I work for the federal government. What? Yeah. The federal government says, oh, you'll take Part A, but you don't have to take Part B. We'll function as your health benefit without you having to take Part B, even after you're retired and you're 65 or older. Well, then I'm not going to take it. Okay, but you better hope that the VA benefit, you better hope that the federal employee retirement benefit is as good as you hope it's going to be for the rest of your life, because you have now passed on Part B, and for every year you pass on Part B, you're looking at a potential delay, more importantly, a potential penalty. So under the current rule, right this minute, if I postpone going into Part B, or Part A for that matter, but stick with Part B. If I postpone going into Part B of Medicare when I was 65 and I passed my entire 7-month enrollment, and I didn't have a legitimate basis for an excuse. I wasn't working. My spouse wasn't working. We weren't covered by an employer plan. I just didn't want it for whatever reason. I can try to go into Medicare B later. I'll be successful. I will apply during the general enrollment period. When's that? Every January through March of each year is a general enrollment where I can submit my application for Medicare Part A and Part B, or the part that I didn't have yet, say my Part B. And under the current rule, I'll finally get it in effect in the following July 1st. Wait a minute, I submitted in January and I got to wait till July? Oh, and by the way, you'll also be penalized. But starting in 2023, we're not going to make you wait till July 1st. Starting in 2023, you still have to do it during the general enrollment. You still reach out January, February, March, but you go in immediately. There's no wait till July. You go in the first day of whatever the following month is. But you're still going to get penalized. You will still be penalized 10% for every 12-month cycle that you coulda, shoulda, woulda, but didn't. And so even though they're waiving the one kind of penalty, you have to wait. They're not waiving the other penalty. That's still the stick that says, if you like the carrot of not having to pay your Part B premium, you better hope that you don't need Part B ever. Because the longer you keep postponing this, the more the penalty builds up. And when you finally say, oh my, this thing isn't working the way I thought it would, I better get into Medicare. So whatever that premium is, plus whatever the accumulated penalty. So if you waited till you're 75, you coulda, shoulda, woulda, 65, but didn't. So for 10 12-month cycles, that's 10 times 10%. Now you're looking at a 100% penalty on whatever the Part B premium is for each month for the rest of your life if you go into Medicare then. If you wait till you're 85, it's 200%. It's whatever the premium is plus a penalty that is 10% for each year you didn't. And that accumulates and it is assigned to you for the rest of your life, or until they change the law, which they may or they may not do. It's a big consideration, especially for guys that are looking at, can I get away without having Part B because I don't want to pay the premium? Possibly. Are you prepared to face the repercussions and take the risk of not having Part B and maybe having to pay a big amount if you ever try to get it again? It's a consideration, at least has to be thought through. Part D, is changing. The big changes I'm going to talk about in November. I'm going to devote the whole session to just how Part D currently functions, is going to function, and staggering in the changes that are brought by the new federal legislation that finally got passed about a month ago, a little bit less than that. Here's the stuff you need to know because it's more immediate. So this is what a Medicare Part D plan currently looks like for 2022. Note, many of the Part D plans have a deductible. Currently, the most the deductible can be is $480. And for non-generic drugs, typically, if the plan has a deductible of some amount, you have to meet that deductible. For the plan then to start splitting the cost with you. I use 75-25 as just an arbitrary split. It could be 95-5, it could be 100-0. Somehow, some way, the plan will cover some of the cost of your medications. You'll cover some, maybe none of the cost when you're in the partial coverage category. But to get there, for the non-generics, you have to first meet the deductible. And that, depending on the cost of your drugs, could be met in the first month, could be met after several months. Only the non-generics typically are assigned generic, or put it a different way, the drugs that are in the lowest tier, tier 1, usually are going to go into cost splitting immediately without meeting the deductible. So you just have to know which drugs are subject to the deductible and which aren't, and calculate when you think you're going to pay the deductible off, if there is a deductible. Higher premium Part Ds tend to minimize or eliminate the deductible. But either way, whether there's a deductible or not, once you've met that deductible, if there is, then the plan and you start splitting the cost of your medications at some percentage for each medication. You just have to look at your Part D to know. But that splitting only exists until you've hit what's called the initial coverage limit, the edge of the donut hole, the edge of the coverage gap. And for 2022, current year, that limit is $4,430. Once you're in the coverage gap, the donut hole, the insurance company says, we're done. We're not going to help. The government steps in and they help at a specific, exact 75-25 split, generics or non-generics. How do you know when you're reaching the $4,430? The easiest way I can explain it is, what's the retail cost of your medications when they add up? I don't care who's paying for it, you, them, somebody. When you have reached the purchase of retail drugs that adds up to $4,430, you're in the hole. How do you get out? You buy yourself out by reaching this next number, $7,050. You get help from the federal government. They'll help you with 75% of the cost of your meds while you're in the hole. You have to pay 25. And ironically, sometimes the 75-25 split is better, or at least as good as what it was when you were splitting it with the insurance company. So, wow, that coverage gap didn't feel very hard. Good for you. When you finally have spent $7,050, you're out of the hole and you're in catastrophic coverage, 95%, 95% the insurance company, they're back online, 5% you. That's how it works now. It's still going to work essentially that way next year. The numbers will change a bit. Get ready, here come the numbers. The deductible is bounced up to $505, so about a $25 bump. The coverage limit is postponed a little bit, so about $170 more, so it's $4,600 for next year. But getting out of it is also bumped up. It ain't $7,050 anymore, it's $7,400, so that got bumped about $350. Once you're out of the hole, still it's a 95-5 split, so it's still essentially the same. There is going to be a significant change, but that isn't going to happen until 2025, when we effectively eliminate the donut hole, we effectively eliminate the catastrophic coverage, and we slap on every Part D plan a $2,000 out-of-pocket max. Now, I don't know what that's going to look like. I don't even know if that's going to look like, because that's a couple years and one big election away. So we'll see. But this is what it is for 2023. Very similar to what it was this year. It's going to be a little different. The numbers will change a bit. When the full effect of the federal legislation that brought about all the kinds of things we've been waiting to see, it's going to have a profound effect on Part D. It's going to impose an absolute maximum on all Part D plans of initially $2,000. It's going to help with the cost of certain vaccines that we take under the Medicare system. It's going to expand eligibility for the low-income subsidy, the extra help program. It's going to help with cost of insulin payments. And it's going to create a means by which Medicare can price negotiate and attempt to control the rampant increased cost of prescription medications. All good things for the consumer. We'll see. This is a timeline. Again, you have access to the recording and you'll have access to the PowerPoint if you want me to send it to you, be happy to. And this gives you at least an idea of this bumpy road to get to the full fruition of the law, which honestly won't take place till 2028. It's quite a while down the road. But it gives you an idea of the things that are coming into effect. What's coming into effect next year? A cap, and this isn't really even the law as much as something that's been in effect, the cap on accessing insulin at $35 a month and accessing to vaccines that will no longer cost. Think shingles, for example. Vaccines that are recommended by the Advisory Committee on Immunization Practices, federal government, will be covered at no copay. The government will help pick that up. This applies to whether it's under Part B or Part D, and it will start next year. What else will start next year? If manufacturers of medications attempt to increase their prices beyond a certain amount, what's the certain amount? Beyond what is deemed to be the acceptable inflation rate, then those manufacturers will be penalized. Their penalty will be the difference between the acceptable increase and what they increase. So basically, the government is taking that from them. The government is. You don't get a piece of that. They're hoping that that value trickles down in keeping the costs of the medications in control. So that's what we're looking for now. But we're going to see a few things in play. And finally, we're going to extend a benefit for individuals that are facing end-stage renal disease. So understand one of the ways you go into Medicare is individuals that are diagnosed with end-stage renal disease. These individuals do not have to be recognized as disabled under the Social Security Administration or railroad retirement, nor do they have to be 65. If they present to the Social Security Administration that they are end-stage renal, they are going to be or already are in renal dialysis or on the list for a kidney transplant, then they will be immediately entered into the Medicare system. However, let's say that the individual entered Medicare based on end-stage renal and got a kidney transplant. Now, in the process of getting that kidney transplant, that individual is likely going to start, even before the transplant, a series of immunosuppressant medication therapies. Now, that immunosuppressant may very well be oral, it may very well be IV'd. If the person was under Part A at the time the transplant took place, under Part A, not Part B, Part A, they were enrolled in Part A at the time of the transplant, then Part B of Medicare covers the immunosuppressants. Why is that a big deal? Because remember what we said about other kinds of meds? 80% covered by Part B, and if you have a Medigap, 20% is picked up. It costs me nothing. I don't care how expensive the immunosuppressants, it doesn't cost me anything. On the other hand, if I'm not enrolled in Part A at the time of the transplant, then that immunosuppressant drug will be covered under Part D. Okay, that's a rule, and that's not going to change, but something else effectively happens, and this is the other thing that's going to change. So I did, going backwards, I did the process that guarantees I'm covered under Part B to pay for my immunosuppressants. And boy, these things are expensive. And how long am I going to take them? For the rest of my life. But here's what happens. If I'm end-stage renal in Medicare and I have a successful kidney transplant. What's successful? It didn't get rejected. How do we know? After 36 months, it didn't get rejected. That's successful. Why is that important? Also, if I go off of renal dialysis after 12 months, that could also be, or if I go off of renal dialysis after being off of renal dialysis for 12 months, I get booted out of Medicare. If I have a successful kidney transplant, after 36 months of the successful kidney transplant, I get booted out of Medicare because I'm not end-stage renal anymore. What defines end-stage renal? Well, technically stage 5 if my kidney's not functioning, the final stage, end stage. But focus for this new change on, yeah, but you got an operation. Yeah. Got a new kidney, yeah, and it's working, yeah. You're not end-stage renal anymore. You got a functional kidney. Yeah, but I got to take immunosuppressants for the rest of my life, and those things cost my soul. Well, look at the bright side. You got a functioning kidney for as long as I take my immunosuppressants. These things cost a fortune. So are you going to allow me to stay in Medicare A and B for as long as I need to, like for the rest of my life? Nope. After 36 months of a successful kidney, technically you're not end-stage renal. Could you be in Medicare for some other reason? Like, are you disabled? No, I've got a good kidney now. I'm not disabled either. And how old are you? I'm 57. Well, you can go in when you're 65. Yes, but how do I pay for my immunosuppressants in the meantime? Not with Medicare. But in 2023, individuals that are eligible for what's considered an indefinite utilization of Medicare Part B to cover the costs of their immunosuppressants. So who's eligible? The person eligible for this is someone that applied for Medicare at the time of the transplant and applied for Medicare prior to the transplant, even if they weren't enrolled at the time. They at least applied prior to the transplant. And it doesn't matter whether at that time Medicare was the primary or secondary. They used an Advantage plan. They used Medicare A and B as primary with a Medigap. As long as you applied for Medicare prior to the transplant, as long as you don't have some other benefit that would pay for your immunosuppressants, like Medicaid or like any other health benefit. So as long as you are in Medicare now, however it's organized, the option one where it's Medicare A and B and a Medigap, or the other option where it's Medicare A and B, but you're having an Advantage plan. Doesn't matter. It's, did you apply for Medicare prior to the transplant? In effect, were you applying for Medicare because it was essential based on end-stage renal? That's what they're really looking for. Yes, that's why I did it, of course. Duh. And then I got my transplant. Good. Because now you're eligible for what? What am I eligible for? To basically have Part B not completely, not exactly, but to have it for the sake of paying for your immunosuppressants. So when's this going to happen? Well, technically, the law got passed back in 2020, December 2020, but it was not going to go into effect till this coming year. January 1st, 2023 is when this law goes into effect. Who's responsible for making sure this runs smoothly? Centers for Medicare and Medicaid Services. So this is a burden not on the Social Security Administration. This is a burden on CMS. Anyone who had the transplant, whose Medicare eligibility was at least applied for before the transplant, they're eligible, and whether or not they were already bumped from the Medicare system already because that 36 months came and went, or literally on January 1st, 2023, or sometime after. So basically anybody that met the eligibility criteria, even if they've been dropped already from Medicare A and B, or they're going to be dropped from Medicare A and B, have the capacity to elect to hold on to Medicare B for the purpose of paying for their immunosuppressants. That's it, not for anything else. So they'll be dropped from Part A, and their Part B will only be eligible to help them pay for their immunosuppressants. This does not extend Part A, and it does not give them a complete and constant Part B. And for those that have already been dropped, the eligibility to try to get back in is earmarked for October 1st. It's already started. So it's not the perfect, let's just keep them in Medicare. No, they're not end-stage renal any longer. But we do recognize that the cost of the prescription medications are so outrageous that without Medicare, particularly Medicare Part B and a Medigap, this may be economically devastating. One other thing, you don't get the Part B for free. It has a cost. Notice it's not as outrageous as $170, or they're going to reduce it to $165, but it's still something. For you to have this Part B to use to pay for your immunosuppressants, you have got to pay a Part B premium. Reduced. Why? Well, because the Part B coverage is going to be reduced as well. And it's also subject to the IRMA. The wealthier you are, on top of the base amount of $97.10, it's going to be some IRMA amount. The IRMAs are also smaller than for regular Part B coverage, but still, it's an IRMA.
Thank you so much for watching this presentation. I hope you enjoyed it, and I hope you learned something. If you would like to know more about our program and the other presentations that we've created on various healthcare-related topics, please visit our website at phbsp.org, or you can call us at 412-266-8322. Either way, I hope to hear from you. And as always, be safe, be healthy. I'll see you later.